Assalamu alaikum. I would like to welcome you back to our echo education series in congenital heart disease. This is the second presentation in congenital heart disease series. This was part of a presentation done at Symposium on Intervention in Congenital and Structural Heart Disease in Bahrain last December. This lecture is about mitral valve advanced imaging. First of all, we need to look at the mitral valve normal anatomy. And in this beautiful cartoon, we could see that this is the mitral valve here with a 2 leaflet, this tricuspid valve with a 3 leaflet. The anterior mitral valve leaflet is facing towards the aortic valve anteriorly, and the anterior leaflet is nearby the left coronary cusp and non-coronary cusp. Furthermore, looking at the anatomy of the leaflets, here we could see the short axis view of the mitral valve, and this is the anterior mitral valve leaflet, and this is the posterior mitral valve leaflet. When the anterior mitral valve open, the papillary muscle will be seen, and as you can see here, both leaflets are attaching to the papillary muscle on each side. There are a few components which is very important. We have the body of the mitral valve leaflets. Here is the body of the anterior mitral valve leaflet. Here's the body of the posterior mitral valve leaflet, and usually it's a smooth part of the leaflet, while the coaptation part, which is this one here, this is the coaptation zone, is usually rough in the leaflets. Here is another cartoon showing the anterior mitral valve leaflet is facing the aortic valve in between the non-coronary and the left coronary sinus. One important feature of the mitral valve leaflets is that the anterior mitral leaflet is larger, and it covers actually 2/3 of the surface area. So this is the anterior mitral valve leaflet is large, and it covers 2/3 of the surface area, while the posterior leaflet is smaller in surface area, but actually it accounts for 2/3 of the circumference. So here the posterior leaflet is covering 2/3 of the annulus of the mitral valve. When you look at the surface area of the 2 leaflets together, they are actually larger, in about 1.5 to 2 times larger than the orifice area. Looking at Chordae Tendinae, we have different types of chordae. We have the primary chords, we have the secondary chord, and we have a tertiary chord. The primary chord called marginal, the intermediate called secondary, and the basal called tertiary. Usually the chordae are about 0.25 to 2.5 centimeter in length, and because of its collagen structure, they do not actually stretch more than 10% of their length. As you can see here, the chordae start with one single origin, and then after that it fans out as it goes distal towards the leaflet. Here there is a nice image while the mitral valve is relaxing and contracting. You can see the chordae are stretched during systole to close the mitral valve. The papillary muscle, we have 2 papillary muscle. We have anterolateral and we have a posterior medial papillary muscle. As you can see here, this is the leaflet here attached to both papillary muscles, and this is the anterior leaflet. The posterior leaflet also attached to both papillary muscle from its sides. So the papillary muscle contract in systole and play important role in mitral valve competence. Papillary muscle ischemia or infarction or rupture may lead to acute mitral valve regurgitation. posterior papillary muscle is more prone to rupture owing to its single blood supply from the right coronary artery in most of the patients. Looking at the mitral valve with a three-dimensional echo is really important, especially in congenital heart disease, because 2D echocardiography require mental reconstruction, while the interpretation for a complex anatomy of congenital heart disease usually does not conform to a standard imaging planes. The three-dimensional echocardiography gives you true anatomic perspective, and also it's very important in guiding in interventional procedures. Live 3D is comparable to those seen at surgery, which we call it the surgeon's view, also which will help in surgical planning and follow-up. Quantitative assessment of septal defects and complex structural heart disease is feasible by three-dimensional echo. Here we are going to show you a few examples of mitral valve diseases. We'll start with this one. So this is parasternal long axis, zoomed view on the mitral valve. You see that there are some thickening of the anterior and posterior mitral valve leaflets. There is a good coaptation. This is the color Doppler. The mitral valve seem to be functioning well without any stenosis or regurgitation. The short axis view here, you notice that there are two orifices of the mitral valve. One is smaller and lateral, and the other one is larger and it is medial. So this is a double orifice mitral valve. When we look at the mitral valve by three-dimensional echocardiography, we can see that we have two orifices of the mitral valve. One is medial, which is the larger one, and this is smaller, which is the lateral one. This is the surgical view. We are looking at the mitral valve from the left atrium towards the left ventricle. This is the double orifice. From the LV side, we are sitting in the left ventricle and looking towards the left atrium, and we can see this is the larger orifice and this is the small orifice, and this is the left ventricular outflow tract. This is another patient with mitral valve regurgitation. As you can see here, there is thickening of the anterior mitral valve leaflet, and we don't see where is the chordae attaching on this view. This is the color Doppler, showing that there is significant posterior directed jet of mitral valve regurgitation. This is short axis of the same patient, and you can see the anterior mitral valve leaflet, and there's a defect at the anterior mitral valve leaflet, while the posterior leaflet is intact. The mitral valve regurgitation jet is originating from this defect in between the two leaflets. This is a beautiful three-dimensional echo looking at cleft mitral valve. This is the anterior leaflet of the mitral valve. This is the LVOT here, and the anterior mitral valve and the cleft is facing the aortic valve and the LVOT. In cases with isolated cleft, while patients with cleft in atrioventricular septal defect, the cleft will be facing the right ventricle and facing the septum. This is LV view. We are looking at the anterior mitral valve leaflet, and this is the cleft. This is intraoperative view for the same patient, where you can see this is the anterior mitral valve leaflet and this is the cleft. Mitral valve repair for a cleft is indicated upon diagnosis to prevent further deterioration of the leaflet, and the repair will be more difficult. This is the third case. This is one patient with rheumatic heart disease, and the patient presented with severe mitral valve regurgitation. This is parasternal long axis view showing that the anterior mitral valve leaflet does not coapt with the posterior mitral valve leaflet. In addition to, there is thickening of the leaflet, and there is a hockey stick appearance of the anterior mitral valve leaflet. In addition to, you can see the thickening of the chordae, both chordae for the anterior mitral valve leaflet and posterior mitral valve leaflet. So these are all features of rheumatic heart disease. When we look at the color Doppler here, you can see posterior directed jet with wide vena contracta. So this patient has severe mitral valve regurgitation. Looking at the same patient by transesophageal echo, this is the posterior leaflet, which is shortened and doesn't really coapt with the anterior leaflet. The anterior leaflet is prolapsing in towards the left atrium. The left atrium actually is dilated because of the severe mitral valve regurgitation. Color Doppler show significant or severe mitral valve regurgitation with a posterior directed jet with the Chordae effect of the mitral valve flow. We have the three-dimensional echo. Here you can see the posterior leaflet, which is really small, and this is the anterior leaflet with its scallops, and there is lack of coaptation. When we look from the other view, we could see that the chordae is really thickened, and there is lack of coaptation between the anterior leaflet and posterior leaflet. We could see the scallops very well. This is the A2 and this is the P2 with a lack of coaptation and severe mitral valve regurgitation. This is post-repair of the same patient. The patient has ring. This is a beautiful image showing the mitral valve is becoming now competent, and you can see some of the sutures in the mitral valve ring. This is the color Doppler of the same patient. There is trivial mitral valve regurgitation and interrogation of the inflow for the mitral valve. It was not stenotic. This is another case with a tissue mitral valve. This patient presented with mitral valve regurgitation. First of all, this is the transesophageal echo looking at this tissue mitral valve. As you can see here that both leaflets seem to be functioning very well and coapting. So what is the source of the patient regurgitation? This is the color flow. You can see here this is a severe mitral valve regurgitation, but it's not very clear why the mitral valve is having so much regurgitation. Looking at three-dimensional echo, this is the tissue valve. These two leaflets are functioning very well, while this leaflet here towards the anterior mitral valve leaflet is not really functioning. So it is immobile leaflet. This is another view from the LV side. You can see beautiful movement of the two leaflets, while the anterior leaflet facing the aortic valve is not functioning, and this is the cause of this patient mitral valve regurgitation. This is another patient with very interesting finding. We have patient with severe mitral valve regurgitation, but we need to know what is the mechanism of the severe regurgitation. Here you could see this is the anterior mitral valve leaflet, this is the posterior mitral valve leaflet, and there is what we call double sign. This is the double sign, where you can see one of the leaflet is prolapsing and above the other leaflet. So this is, when you see this sign, it is a sign of rupture mitral valve leaflet, and actually you could see the chordae is prolapsing into the left atrium. This is the same patient, where you could see the anterior directed severe mitral valve regurgitation jet. This is Flail posterior mitral valve leaflet. When you see this double contour in the mitral valve due to posterior mitral valve leaflet flail. Here is the chordae is protruding into the left atrium, and this is the severe mitral valve regurgitation. When you look at this same patient by three-dimensional echo, we can see this is the posterior leaflet with its three scallop. This is P1, P2, and P3. This view from the left atrium towards the left ventricle. This is the surgical view. This is the left atrial appendage. This is the lateral. And this is the anterior. This is the aortic valve, which is lying anterior to the mitral valve leaflet. Here is the P2 scallop with its chordae. It is a flail, and it is protruding into the left atrium. Again, this is similar view, and you can see the flail leaflet into the left atrium. This patient underwent successful repair, and the posterior leaflet is not actually protruding into the left atrium, and the mitral valve is nice and competent. So this is successful repair documented by this esophageal echocardiography. This patient has a mechanical valve, and this is transesophageal echo looking at the mechanical valve. This is one of the leaflet of the mechanical valve, and this the other leaflet. Normally, the two leaflets should actually move symmetrically. In this case, one leaflet is moving and the other one is not moving. So this will cause malfunction of the mechanical valve, and it will lead to either stenosis or regurgitation. So in this case, we have this valve leaflet is not moving, and there is significant mitral valve regurgitation, and there is stenosis on the other orifice of the mitral valve. When we have the three-dimensional echo, it will be more clear. So this leaflet is stuck and is not moving, and this leaflet is fully functioning. Here, this is three-dimensional echo from the LV side. We are looking at the two leaflets. This leaflet is opening and closing, so it's moving disc. This disc is stuck due to either pannus formation or fibrosis. Sometimes it could be due to endocarditis. This is the same patient. So this is the mechanical valve, and this leaflet is moving. This leaflet is stuck. So this leaflet is stuck while it's open, so the patient will have severe mitral valve regurgitation. This is after replacement of the mitral valve for the same patient. Here you can see this is the new valve, and the new valve, both leaflets are moving symmetrically. We have minimal mitral valve regurgitation, and this is what we call it washing jet of the mitral valve mechanical leaflets. It is acceptable. The patient has no paravalvular leak, which is very important in the assessment of this patient. This is three-dimensional echo for the same patient, showing beautifully the mitral valve leaflet. Both leaflets are moving symmetrically and the valve is opening very well. So this patient has successful mitral valve replacement. At the end, I would leave you with this Saudi red sand dunes.